All right, thanks everyone for joining in person and online today. We are going to talk about restricting abortion access, local and global implications for reproductive health. And I am mostly going to leave the talking to my experienced colleagues. We have Gina Dillon, who is actually joining us from Kenya now. You can see her on the screen. Gina is an associate director at IPAS, North Carolina, and has worked in the field of sexual and reproductive health for about 16 years. IPAS is a Capitol Hill organization that works to expand access to safe abortion and contraception globally. And Gina has developed strategies for reform of restrictive abortion laws and ways to respond to opposition threats. And she works to ensure the broad interpretation of these laws and policies to maximize access to abortion. And she's also provided general support on legal issues during her time at IPAS, including providing support for lawyer trainings and helping develop expertise around criminal procedure violations in the context of the criminalization of abortion that we're continuing to see. This is Dr. Beverly Gray. She is an associate professor in Duke's Department of OBGYN and has board certification in complex family planning. She's originally from North Carolina, from Western North Carolina, and completed her undergrad and medical training at UNC Chapel Hill, after which she came to Duke for residency training. And she currently now leads our OBGYN residency program and serves as the division director for the Women's Community and Population Health Division. And her clinical interests are the complex family planning, OB care, and transgender health. Research interests include contraceptive counseling, pain control during GYN procedures, and medical education. And fun fact about Bev is that while at UNC, she was not the Tar Heel, but she was in the pep band and then played in the ska band. Next to her is Dr. Jonas Schwartz, another OBGYN at Duke with a board certification in complex family planning. Jonas is originally from Durham and was an undergrad at Duke, after which he went to UNC for his med ed and MPH. Then he went out to Oregon for OB residency and came back to UNC for the family planning training. After fellowship, he joined us here at Duke and splits his time between clinical work and research. And his research interests include health policy issues that impact the underserved. And he seeks to build evidence that can help reduce health disparities with a special focus on immigrants, Medicaid policy, and access to abortion. Dr. Gray and Dr. Ford are leading About Connections in the fall to specifically talk about the implications and life in a post-Roe world. Fun fact about Dr. Ford that all of us should know is that while an undergrad, he was the Blue Devil during his senior year. So our Blue Devils will appreciate that. So in addition to everything in their background, both Bev and Jonas, and I'm sure Gina, have put in countless hours and probably the equivalent of a second job since June when the Dobbs decision came down. And we see them dealing with the real impact of Dobbs on patients within the Duke system, around North Carolina and across the country, both in a clinical realm and in a policy advocacy realm. So I will turn it over to you guys to start talking about your work.
Well, thank you for that introduction. And the way we've structured this talk is, so Jonas and I give a lot of talks about abortion care and access and implications of the Dobbs ruling on care. So we'll start with a little bit of background. And then Gina's going to talk some more about kind of global impacts of abortion restrictions and how what she has learned in her work may now benefit some of the areas in the United States that are facing restrictive bans. So we will get started. All right, so as far as disclosures, I am a PI for an IUD phase 3 trial, but that has nothing related to the work that we'll be talking about today.
I am a next belong trainer for Merck, also nothing related to what we're discussing today.
But I think the most important disclosure is that we both know and love people who've had abortions, like many of you in this room. And for me, that person was my grandmother, who in the early 70s found herself with an unplanned pregnancy and a diagnosis of cervical cancer. And at that point in North Carolina, she did have access to abortion care because it was a threat to her life. And it's just constantly surprising to me how in some states in the US, if my grandmother were living today with that same situation, she wouldn't have access to care. And so I think, we've been talking to a lot of folks, a lot of legislators, a lot of other groups, and it's always surprising to us how many people bring forth a story of how access to abortion care has impacted their life, whether it's for miscarriage care or abortion care. It affects so many people. And really, people don't know how they'll face that choice until it's in front of them. And so I think for people who've had that experience in their life, they have a very different mindset around abortion access.
So we're going to talk a little bit about the statistics of who seeks abortion. And in our part, we're going to focus really on care in the United States. We'll talk about current legal barriers that patients face in North Carolina so that you can understand what it's like to abortion here. And then Gina will talk about international abortion statistics and then talk about how previous international work, specifically around abortion prevention and harm reduction, now may unfortunately apply to U.S. populations. You go for it.
Okay. So this issue is complicated, and there are a lot of folks with goodwill on all sides of the issue. I think as a medical professional, we focus on sort of the impacts on health, and really our goal is to bring sort of a nonpartisan discussion to this issue, which is really important. I think the events of this last summer and with the Dobbs ruling, we've just really been reflecting on the future for North Carolina, the future for the US, and really the future for the South, where many would argue that we've been living a post-Dobbs existence for a long time anyway, because access is variable.
Go ahead. Yeah. So we showed this quote: abortion is a fact of life. Women have always had them and they always will. Are they going to have good ones or bad ones? And unfortunately, that is the choice that is facing many people, both in the United States and then around the world in places where abortion is illegal and difficult to access. I think that it's important to know that when we talk to our colleagues who practice in the pre-Roe era, there used to be wards at all the hospitals that cared for people who had illegal abortions and were having complications of those illegal. And so many people's introduction as nurses, as doctors, when they were, in OBGYN, was that they were caring for very sick patients on these post-abortion wards. Fortunately, we have abortion is really safe. So when you have access to legal, safe abortion is really safe. It's one of the safer things we can do in medicine. And it has, a fantastic safety record. We know that the regulations that people are proposing only make abortion more difficult to access. They don't actually make it safer. When we take away legal access, it is likely still that people will continue to need abortion. They will access it through extra legal mechanisms. And fortunately, we do have abortion pills, which will probably be the main route of access and probably will continue to make it safer. But it does mean that there's a big change that is happening right now in the United States in terms of how people are accessing these essential health.
So before Roe, like Jonas was mentioning, people sought means for abortion care outside of the system and used medications, other tinctures, other ways to achieve the care that they needed. Maternal mortality was very high in that era, and mortality related to abortion was also high. But I think the important point that we want to point out with this slide is that it mainly impacted people of color in this country, those mortality rates with self-managed abortion. I think that one of the main points we want to convey is that with self-managed abortion with medication, it is much, much safer. Despite a lot of misinformation out there about medication abortion, it is incredibly safe. Despite all the regulations around mifepristone, which is the first dose of medication with medication abortion, it is an incredibly safe medication and much safer than many of the meds that are over the counter. So safer than Tylenol, safer than ibuprofen. And so we're worried about impacts of bans on patients who are already having difficulties in accessing care, paying for care, and who may seek other ways to achieve care. And this graph is just always very striking to me. After legalization of abortion care in this country, the number of deaths dramatically decreased. So there is a connection between maternal mortality and access to abortion care.
The point of these next couple slides is to tell you a little bit about what abortion care looks like in the United States from a statistical standpoint. Unintended pregnancy is really common in the United States. So almost half of pregnancies are unintended. Abortion is also a really common experience. You love someone or know someone who had an abortion because it's really common. 1 in 5 pregnancies end in abortion, and 1 in 4 women will experience an abortion before menopause. And so this is just an essential component of healthcare that many people need. The majority of abortions are very early in pregnancy. So about 2/3 occur in the first trimester, actually before 8 weeks. And then a full 85% do occur in the first trimester, the segment that are from that 8 to 13 week mark. And then it's much rarer to have second trimester abortions. And often the patients who need those second trimester abortions are people who have medical complications of pregnancy, who have genetic or fetal indications for the abortion, or who had difficulty for some reason accessing the abortion previously. One big group that we think about are teens. Think about it. If you are a young person, you may not have regular periods. That's very common. You may not realize that you're pregnant because there's no sex education in North Carolina that's standardized. When you realize that you're pregnant, you may not want to tell your parents. You may not be able to figure out how you're going to get to abortion care. And so that's a big group that we know get delayed in many states. Abortion, the need for abortion does cut across races, it cuts across religions. The majority of people who have abortions already have a child at home. So there is a really common myth that it's these irresponsible young women who need abortions, when in fact, the majority of the patients we care for are making an active decision that they want to devote their parenting resources toward the kids that they already have. You will notice that there is a disproportionate concentration of people who need abortion who are young. Those are also more fertile people. There is a disproportionate concentration of abortion among people who are low income, who may have other barriers to access to sexual and reproductive health care.
In North Carolina, about 50% of maternity care is covered by Medicaid. And Medicaid in North Carolina does not cover abortion services. So in some states like California, Massachusetts, there's state funding available for patients who have Medicaid funding for their health coverage, but not in North
Carolina. So prior to Dobbs, the North Carolina was one of the most hostile states in the country in regards to abortion care. And post-Dobbs, North Carolina remains a hostile state in regards to abortion care. But it's whatever the opposite of the rising tide raises all ships is. Our neighbors have gotten worse and have introduced bans on abortion. So Georgia has a 6-week ban. South Carolina currently has an enjoined ban, but will ban again. Tennessee has one of the strictest bans in the country. Kentucky has a ban. Alabama, Mississippi, Louisiana. So all those red states, no political pun intended, all those red states there literally have bans on abortion care. So it is really difficult to access abortion, particularly in our region.
And for me, these maps are very striking. So this lays out, the number of clinics providing care pre-Dobbs and post-Dobbs. And this is from a website called Power to Decide. And so they have a lot of information there. The Guttmacher Institute also is another great resource for information around kind of what's happening state to state. but many of these states have closed their doors to care. And as a result, patients are either not seeking care and continuing pregnancies, or they're coming to another state like North Carolina.
So when I say that North Carolina is hostile to abortion care, the things that patients seeking care here face, we have a 72-hour waiting period. So people have to have state mandated counseling. The content of the counseling is mandated before they seek abortion care. They have to wait 3 days to have their abortion after that care. Only doctors are able to provide abortion, despite the fact that there's excellent evidence that advanced practice providers, nurse practitioners, midwives, can be skilled abortion care providers and safe abortion care providers. Parental consent or judicial bypass is required for minors who wish to have an abortion. We aren't able to provide abortion through telehealth, even though we know that we could safely provide medication abortion through telehealth. And then Bev mentioned the economic barriers to care, that abortion is not funded not only for Medicaid patients, but also there's no abortion funding no abortion care is allowed through the state employee health plan. So firemen, policemen, faculty at UNC don't have abortion coverage as part of their health insurance. And then we frequently see people with private insurance who don't have abortion coverage. Duke does actually provide abortion coverage through both the Duke Basic and Duke Select plans.
So we know that restrictions do not make care safer, despite what politicians will say, that these bans are to protect women. They don't protect women. They don't decrease the rates of abortion. They don't protect the patients that they're aiming to serve. And so it's a lot of theatrics around kind of, oh, we want to keep care safe, but really access to care is what keeps care safe. And the disparities in maternal health outcomes, I think, are really important. There's a lot more data around what's happening in states where abortion is restricted, and what's happening to patients in pregnancy who live in those states who have outcomes. Maybe they break their water early and are hospitalized and have to wait until they're really sick for care. That doesn't help people. And so there's some really great information from the Institute of Medicine, sort of outlining all the data around the safety of abortion and the impacts of bans on access. And so I think that's a really helpful tool if you're interested in learning more. And we've talked a little bit about kind of these reasons why people may seek abortion either in early pregnancy or later in care. And we talk a lot about how, pregnancy is not always, rainbows and butterflies. It's like a marathon, like being pregnant is like running a marathon on your body. And so for most healthy people, it works out okay. But if you have other health complications, you're diabetic, you have high blood pressure, you have any other medical comorbidities, it's harder to run that marathon. And often in the second trimester, people start having impacts on their health. So we'll see patients who have kidney failure, heart failure, other just severe exacerbations of their medical condition. And if we limit care at some arbitrary point, we're not able to provide care to those folks. So in Texas, some of our colleagues sort of looked at their data around patients who had some sort of issue before viability. So kind of around that 22-week period of time. Maybe they broke their water early. Maybe they were diagnosed with early preeclampsia, which is a condition unique to pregnancy. And they decided to compare them to patients before the ban. And so what happened to these folks, to their pregnancies? And so of those patients, 60% of them had some sort of bad outcome, whether it was needing to be admitted to the ICU for severe infection, needing a blood transfusion. Luckily, none of those patients died, but in my experience, some of the sickest patients I've ever seen are patients who break their water early and then become septic or have a severe infection. And so it's unfortunately likely to play out in states with these bans, is that we're going to see this continue to happen, this putting these patients at risk. Because providers are fearful to care for them.
So I think this is the data that was available at the time I put together the talk. There's recent data showing, in short, that states with abortion bans are 3 times more likely to have people die during pregnancy. I mean, it just is it's there. You know, I think one thing that I hope comes across is that the scientific evidence on this is not particularly disputable. Unfortunately, that's not what's being debated. And it doesn't feel like what people who are advancing abortion bans, doesn't feel like that's what they care about. And so the 2 groups that you have at the table are ideological people who are against abortion and people who are talking, doctors, patients, scientists who are talking about the science behind the need for abortion. And the fact that those 2 groups are opposing about something that's a healthcare choice, to me, really doesn't make sense.
The other study I would point you to if you're interested in this topic is the Turnaway study from UCSF. So this study took place over a decade. They recruited 3 groups of patients. They recruited women in the first trimester who lived in a state where they could access abortion, women who were accessing abortion in the second trimester, and then a 3rd group of patients, the Turnaway group, who were just over the legal limit in their state, and they were matched to these other patients in the first and second trimester group. And so they kind of followed them over this decade to see what would happen. And there were 170 women in the Turnaway group, and in that group of women, 2 of them died of immediate postpartum complications. So already this Turnaway group is high risk. So that I think is clear. And then there are all of these other ramifications on being turned away from care. So those women were more likely to remain in poverty. They were more likely to remain with a partner who was abusive. They were more likely to have bonding issues with their children. They had mental health impacts. I mean, there are, I don't know, like 100 papers out in the study talking about all of the ramifications of being turned away. And Diana Green Foster, who's the main PI of the study, has a whole book about the findings. So I would encourage you to check that out. But I think there are harms from banning access to care on an individual basis and just for women in general. Their main point is access to abortion is life-saving, and for some patients, life-altering. And I think there's a lot of evidence to support that. So we, like Dr. Hutchko mentioned, have been very involved in advocacy, and we have an advocacy group that's open to any member of the Duke community called the Dream Team, because every good group has a good acronym. So it's the Duke Reproductive Health Equity and Advocacy Mobilization Team. And so if you're interested in being involved in that work, please feel free to reach out to either of us. And we can put you on a listserv. And we've been meeting with folks like David Price. We've been working with Representative Von Hafen from Holly Springs, who's been a staunch advocate for abortion access, and others. And so I think it's, we've been learning how the sausage is made at the legislature, and it is not a pretty process, that's for sure. And don't be surprised when you see in the headlines in this next month or two that they're posing a 13-week ban in North Carolina. So I think if for folks that are paying attention, they know that this is coming, and I think that's what we're predicting. So there's a lot of work to be done. If you want some more background information about abortion care in North Carolina and in the South, Jonas and I did a podcast for WUNC back when the decision leaked back in May, which is a whole blur. But it has a lot of background information about abortion care, who accesses care, some of the information that we talked about here, but it's like a 15-minute talk if you want to listen to more. And that's all we have. This is a picture from the beach. I was on vacation when the Dobbs decision came out. I was really annoyed by that. But this was for my morning walk that day. There was a lot of melancholy in the air. But, so that is our portion of the talk. And we're going to pass it over to Gina.
Hi. Thank you. I hope you can hear me. And thank you for having me for this important conversation. And apologies for any connection issues. And thank you to my colleagues in the room for advancing the slides for me. So I'll be talking today about the global impacts of the overturning of Roe versus Wade on sexual and reproductive health and rights, and specifically abortion access. That is the focus of our work. So at IPAS, we believe in a world where every person has the bodily autonomy that they need so that they can determine their own future. Our mission really involves working globally to advance reproductive justice principles grounded in a human rights framing by advancing access to abortion and contraception where it's either heavily restricted or simply the needs aren't being met for the population. You could advance, yeah. This is specifically where we do our work, although noting that this list of countries is always changing based on local needs. So we sometimes work in countries or add countries to our portfolio depending on what's happening, as this is a constantly changing area of the law, unfortunately. So our CEO, Anu Kumar, has spoken out about abortion access denials around the world. And when Roe was overturned, it was no different. In fact, it was really acute for us. We have a US office based in Chapel Hill, although no longer anymore since the pandemic. And we're also really well connected with local and national partners here in the United States. We know what it means to live in a restricted setting for abortion. That's the work that we do. And like many others in the US and what we've heard today, we saw this coming, yet it was still a shock. And it's also really important to acknowledge that abortion restrictions are closely connected to an undermining of democracy and democratic ideals around equality, fairness, and justice. And abortion too often gets thrown into the political machinery as a wedge issue, and it's incredibly effective. And while we're all impacted, it is usually the most vulnerable, the already disenfranchised groups that are the most harmed by these kinds of restrictions. So this slide, there's a lot here. The purpose is not to spend a lot of time walking through the history of abortion regulation in the US, although I would love to do that, and I do that sometimes in another life. But the slide is really meant to visually describe the trajectory of abortion regulation and to show how politically fragile it has been in this country. As we heard earlier, there was minimal regulation prior to Roe, and it was a small group, I say elite doctors here, just to recognize the point made earlier that this was advocacy by providers, but it wasn't necessarily equitable. So not everyone got access, even after Roe. And before Roe, there was inequitable access to abortion. Unlike many of the countries where we work in the United States, it's been the judiciary where federal abortion regulation has really come. And you can see from the slide here how abortion access really became most fragile and vulnerable to the political winds after the June medical case. And unfortunately, shortly after which our savior, Ruth Bader Ginsburg, passed. And during a window when there was time to install an incredibly conservative, radically conservative Supreme Court justice. And from there, you see it's just downhill. So when Roe was overturned, we asked our country office leaders to share what they were seeing. Legally, there is no direct consequence of this change in domestic US law, but politically and socially, the restriction was felt almost immediately. So I won't read the slide here, but I think it's worth noting that in Kenya, in particular, US policies already carry a lot of weight. USAID restrictions, the progress that had been made was incredibly fragile and was decades-long work by committed advocates. And when Roe was overturned, the effect was felt immediately that policymakers were more chilled in speaking about abortion. Anti-rights actors were incredibly emboldened to hold this decision up as a victory. The next slide shows what some of our leaders from Latin America and from the Asia region shared. Our country leader in Bolivia talked about how this is likely to have a reverberation on other rights and other important issues in the region, particularly around access to care for survivors of sexual violence, LGBTQ rights. In India, abortion access is, there has been progress made, but the anti-rights actors and opposition have really grown in the last year or so, which is something that we hadn't previously seen, such an active mobilization of anti-rights actors in India, where abortion is legal and has been pretty widely available and accessible for many people there. We've also seen policymakers in Nigeria and Malawi walk back some of their previous commitments on expanding abortion access. You can visit our website to see more quotes from country leaders around the world about what they're seeing. And we really, when we think about our work, the way we approach it is that we think about the abortion ecosystem. So it's not just the health system or the law, it's the environment around a person when they're making their abortion decision. What the Supreme Court decision did in countries around the world was, as I said, really embolden their anti-rights opposition. These are environments where there's already a lot of stigma, a lot of hostility, harassment of abortion providers and people who are seeking abortion. So where they were already operating, they really dug in and held up this decision as a victory. Where we hadn't previously been seeing them, they became more active, with India as a good example of that. You could advance. Movements that are in opposition to sexual and reproductive health and rights, human rights, democracy, and gender equality have been growing for many years now. There have been a number of right-wing electoral victories, along with the fear and the isolation that was caused by the COVID pandemic, all of which has really emboldened them to take more action, go further than we've seen them attempt to go. And this is evident in some of the restrictions that have been proposed and passed in the United States. At IPASS, we've made a significant investment in monitoring and addressing opposition movements because this has always been a major threat to progress in our work, to the safety of our staff and our partners. And it's never been more apparent now that not only are sexual and reproductive health rights and abortion access under threat, but so are other liberal democracies, the civil liberties, the human rights of everyone. Anti-rights actors are diverse. They're well-connected. They work across religious denominations and political affiliations and geographies. It's important to note, too, that there's no single opposition movement. The threats come from a web of actors that are incredibly well-funded, highly motivated, and very politically savvy. And the threats are intersectional. It's not just about abortion rights. It's about gender equality writ large, civil rights, LGBTQ rights, voting rights, girls' education, the list goes on. And as you can see here, the message, as we saw in the previous presentation, it's one that we've always had as well, that, and we're repeating more and more here in the US and everywhere that we work, restricting abortion does not reduce the number of abortions. We know that. And if pills, abortion pills, information and support networks are not available or readily accessible, abortion care tends to be driven underground and it becomes less safe, dangerous, even deadly. So for a number of reasons, Roe's overturning being a major one, from our perspective, the US is really losing a lot of its legitimacy and its credibility in global, international, and human rights spaces. But I have to say, the news is not all bad. On a more positive note, you could go to the next slide. The global trend really is towards liberalizing laws and greater acceptance from a global perspective. Just last week in France, the Senate approved adding the right to abortion into the national constitution. Now, the final result is still TBD. There's a little bit of drama around that. Here in the United States, though, voters in Kansas approved adding the right to abortion into their state constitution. You can see here from the photo, feminists celebrating the Supreme Court in Colombia legalizing abortion until 24 weeks. Chilean activists were in the street states asking for inclusion of abortion in their new constitution. Unfortunately, that measure failed, but the level of engagement and movement that we saw, the green wave, as it's commonly referred to, was really powerful and really demonstrated that there is a trend in the direction of progress. In Argentina, the Congress and the president legalized abortion without restriction in the first 14 weeks. Ecuador's highest court decriminalized abortion in cases of rape. The Mexico Supreme Court unanimously ruled that it was unconstitutional to criminalize abortion, guaranteeing the right to choose an abortion. In Nepal, the government has included abortion care in its package of national health services that are offered free of charge to anyone who needs it. In the Democratic Republic of Congo, the Maputo Protocol, which is a regional, Africa regional human rights treaty, and the only one that specifically recognizes a right to abortion. It was recently accepted by government officials in the DRC. It was ratified and incorporated into national law. And even more recently, the Ministry of Health there really endorsed progressive standards and guidelines for comprehensive abortion care. Now we know at IPASS that these developments don't necessarily and automatically translate into increased access, but they're really important steps, really important signals that this is about healthcare, this is about saving lives, and it's moving us towards the reality that we know, which is that abortion is healthcare. You can go to the next slide. And so, as we mentioned earlier, I do think it's worth mentioning a little bit about our approach. We are starting to ramp up more programming in the United States because, unfortunately, our tools, our resources, our approach is more relevant now than ever in the US. So I mentioned earlier that we approach our work through the lens of the abortion ecosystem. The first step wherever we work is always looking at the environment and starting conversations with the relevant stakeholders. When abortion is heavily restricted, you can bet that there's stigma, there's resistance, and even silence in some pockets of the ecosystem. We've developed tools that help us break that silence, to help give people a safe space to dialogue with partners, with colleagues, with community members, about a topic that they might be uncomfortable with, or that could even be dangerous for them to speak about publicly. Next slide. We also look at global clinical trends like the recent World Health Organization guidelines. These are an incredible, monumental step forward in terms of global health rights-based guidance on abortion care, recommending that abortion be decriminalized, that self-use of abortion should be available, and that barriers in law and policy should be removed, advocating for telemedicine where it's possible. And so what we did is we developed an advocacy-oriented guide that helps to advance access through implementation of those WHO guidelines. I really recommend US activists take a look at this. It's a really powerful, the WHO guidelines, and of course our advocacy guide if it's of interest. But these guidelines are really important, and we've heard some stories of clinics in the US really looking at these guidelines in terms of the care that they provide and the restrictions that they're trying to navigate. We also create really practical tools like the How to Have an Abortion with Pills resource that's shown here. And all of these are available on our website. I mentioned advocacy, which of course for us means monitoring the opposition and supporting like-minded colleagues who are interested in advancing access in their setting, but who may need some help getting started. So we have a password-protected opposition research analysis and action guide, which is available to anyone who is interested. If you can contact IPASS, we can do our background and grant you access to that. But we also have Roots of Change, which is our step-by-step advocacy planning guide that we use with youth activists, feminist groups, and other stakeholders around the world. And I wanted to also just share a few pictures of some of our efforts, particularly in the Francophone Africa region, where really, in some of the places where we work, nobody or only one person is able to, be brave enough to work on abortion. Our work really involves finding more people because this work can't be done in isolation in a restricted setting. Movement building is really critical to everything that we do. And the last thing I'll say is just in the last year to recognize that we've really updated our brand, our materials to be more explicit about our role in collaborating with partners in solidarity and furtherance of reproductive justice principles. We are prioritizing equity and inclusion. We're looking at all corners of the abortion ecosystem as a way of ensuring abortion justice. We're taking on intersectional projects that are helping us learn and grow about our own work, but they're also helping partners outside of the abortion sector think about how and why abortion access is relevant to them. So for example, climate justice activists, activists that are working in humanitarian and conflict settings, those that are working on gender-based violence or comprehensive sexuality education, disability inclusion, and more. And so I'll just end with a reminder. I don't think this group needs it, but just something that we try to say as often as possible is that it's not political. Abortion is healthcare. It's not a crime. So thank you very much.
Well, that was amazing. Thank you to all three. And we're going to open it up for questions. We have one already from the chat. Okay, we'll start.
So Rachel asks, what does the state mandated counseling consist of? Is it education on the procedure or an attempt to stop an abortion? And then are there statistics on the number of people who seek out an abortion and then change their mind after counseling?
So the state mandated counseling is, I mean, I think it's disrespectful, first of all. I mean, it's making this assumption that healthcare providers are not providing adequate counseling to their patients, which we absolutely are. Some of it talks about just the risk of abortion, the risk of pregnancy. Some of it is very disrespectful to the patient. So let's say you have a patient who has a medical reason why she's seeking abortion care. I'm required to tell her that the father of the baby is liable to pay for child support, even if he's supporting your abortion care right now. That's a statement we have to read to every single patient who has an abortion in North Carolina, according to the statute.
Including rape victims.
Including rape victims. Yeah. So it, you know, sometimes we'll preface it by saying, you know, listen, this is required by the state. When you come here, we're going to go through all the risks, all the information you need to have to make a good decision for yourself. But this is required by the state. Some of it may not be applicable to you in your situation. Some of it may seem insensitive, but we're required to read it. And then as far as,
you know, I don't know that if there's like formal statistics on how people change their mind at the time of an abortion visit. And actually that'd be pretty difficult to collect in terms of if you think about the different ways that we do data collection. I'll tell you that in my experience as a provider, it's pretty unusual. I would say, you know, there are people who come and are ambivalent about their pregnancy and come for sort of options counseling, and we provide comprehensive options counseling and sort of help them make the decision and, you know, lay out what are the things that are leading you to not want to continue the pregnancy, what would lead you to want to continue the pregnancy, and here's what you understand. So I would see that differently than either change your mind or regret. We know that the risk of regret from the Turnaway study after abortion is very low. So the predominant emotion that people feel immediately after their abortion is relief. And then there are two other themes that sort of come up. So one of the things that the state mandated counseling requires is that we direct people if they would like to see an ultrasound and hear the heartbeat of their baby, I believe is the language, that they should go to a crisis pregnancy center. If you're not familiar with crisis pregnancy centers, they're pseudo clinics or, you know, they look like healthcare facilities. People wear white coats and they're not operating under healthcare. They're not operating under a healthcare license. They do ultrasound, and their express purpose is to talk you out of having the abortion. They often are co-located or located very near an abortion clinic. And so they try to, you know, loop people in, intercept people who are on their way to abortion and talk them out of it. And so we've seen a number of patients, particularly recently, who have actually had problems as a result of having gone to a crisis pregnancy center. They've gotten inaccurate gestational age dating. I had a patient who was misdiagnosed with a new pregnancy when in fact she was having a miscarriage. You know, we're happy to provide care that is not abortion care. And so people should not be directed to these facilities where they are getting misinformation. The other thing that some state mandated counseling requires, not in North Carolina, is that the providers talk about abortion reversal, which is not a thing. So the idea is that so medication abortion, that you can reverse your medication abortion, and this is not a medical thing. If you take the first pill in the medication abortion and you don't take the second pill in the medication abortion, about 40% will have an ongoing pregnancy. The idea of abortion reversal is that if you give high dose progesterone after taking the first pill, that it may reverse the effects of the first pill and cause you to be more likely to continue the pregnancy. The issue with the data is that people were recruited for this, like non-FDA approved, non-unstudied sort of research regimen, not told that they were part of that, and then called these hotlines and then given these progesterone regimens. And so, I mean, I'm hopeful that in this iteration of whatever's coming out of the legislature, that will not be something that they require us to do. And we're trying to provide that education for our legislators so that they know, listen, this is not a scientifically based thing. This is just anti-abortion trope. The other component of that is that it's very rare that people would be seeking that service. It's very unusual that they want to stop after having had the first pill in a medication abortion.
And we had some colleagues in California that tried to study this in a randomized way. So they randomized patients who were planning to have, I believe, a surgical procedure into groups where they got mifepristone and then received this progesterone rescue. And they actually had to stop the study early because there were some negative outcomes in the group that received the progesterone. So unscheduled visits to the ER for heavy bleeding and hemorrhage. So I think even in attempts to study it, it's not safe to do that yet. It's required that we say that. I think the other piece of kind of important information is that when they ask patients how they feel about this counseling, most patients are like, yeah, it doesn't really apply to me. Maybe it would help somebody else, but not me. But no one finds it helpful. And I think that's reassuring. I think the other thing is, when people make up their minds and they call to make an appointment, they've made up their minds. They're, adults making a healthcare decision. And then to say to them, you know what, I really want you to rethink this for 72 hours and go sit in the corner and just think about it. And that's just ludicrous to me.
Answer has done, that group that did the Turnaway study, Ushma Upadhyay has done studies on abortion certainty, and they rank it next to certainty for other procedures, and abortion certainty is higher than like prostate surgery if you have prostate cancer, and knee replacement surgery. It's one of the highest rates of certainty once they make that decision. And she also looked at women, whether they change their mind after an ultrasound, and seeing an ultrasound with a heartbeat was not shown to change people's mind, again, because these are fully functioning human beings that have sentient mind.
Thanks so much for this. It's really, really important discussion. I have a question about the policy implications and the data, if we have any, about exemptions. There of course are a number of laws that have been passed or that came back into play after Dobbs, zombie laws, that do have exceptions. So bans except for life of the mother, incest, rape, those kinds of things. But it's appearing that they actually, it's very, very hard in practice to for these to function, and that they really play a role of sort of making these laws seem more compassionate and caring than they actually are.
I think exemptions are complicated. And, if I could make a cookbook of how to be an OBGYN providing abortion care, that'd be great, right? But there's no way I can make a cookbook of these are all the things that you need to consider. I mean, we face things and conditions that we're surprised by on a monthly basis, things like, oh, I never would have imagined I would have encountered someone with X condition with pregnancy. And so to try to make a list, you're always going to leave someone out. And then I think there's this, we want to kind of get away from this narrative of good abortions and bad abortions. Do you make the list or not make a list? I think.
Yeah, I mean, I think that there aren't data that are good yet because of I mean, for a bunch of different reasons, but one of them being that it is relatively new in terms of how you would gather the data. What I can tell you is that speaking to our colleagues around the country, and our care in our clinic, our volume has doubled since Dobbs. So we are seeing twice as many patients in our clinic. We both work at Planned Parenthood as well, and the volume has more than doubled there. North Carolina is one of the states that has had the highest increase in the number of people seeking care here. And the situations where people are seeking care, sometimes it's within potentially the exemption. Sometimes there's lack of clarity about the exemption. And then there's an overall chilling effect on all sorts of care that is provided for people who become pregnant. So one example is that if there's a ban in your state and you have a drug that is poorly studied about what its effects would be on pregnancy, or could potentially cause harms on pregnancy, can you still give that drug? So our colleagues in rheumatology have had debates about whether they should even give people drugs that potentially would cause health defects. So then it's people who can't get the care outside of pregnancy that they need because that drug could cause harm in a pregnancy that they got. People who have cancer in pregnancy, Bev mentioned earlier, they often will make treatment decisions that are, as they should be, focusing on their own health or balancing their own health with fetal health. But if you were, deciding between treatments, would you offer the pregnant person the treatment that would be more effective for her, but potentially higher fetal harm? Will she be able to make that decision? So I think what we've seen is that those exemptions are universally too narrow, and that this idea of being able to decide even when the life of the mother is at risk is really, really hard. Bev and I had a discussion about a patient who we cared for who had about a 1% risk of death in pregnancy, so 100 times her baseline risk. And is that, can she then have an abortion that is for the life of the mother or not? Does that not meet criteria, right? It's a personal decision about where that line is. And I haven't seen, I don't know, people aren't making the laws with that degree of, nor should they, right? With that degree of sort of decision making that would allow maybe doctors to make a decision, right?
I think the other thing that we're seeing in Tennessee is that it's like an affirmative defense. So if someone accuses a provider of providing an illegal abortion, they have to defend themselves for the care that they provided. And so what if they feel the risk is unacceptable, but whoever's charging them doesn't? Mm-hmm. So it really impacts the care they provide.
Another question. Yeah, so Aurora says that I definitely agree that laws do not translate to access. What measures can you look at to gauge access to abortion care in a country with legalized abortions like India?
That was Regina, right?
Could you repeat the first part? I heard the end, but the first part.
Aurora says, I agree that laws do not translate to access. What measures can we look at to gauge access to abortion care in a country with legalized abortions like India?
Yeah, it's a good question. And what's really important is sort of the conversation happening. So our work to work with both community members, but also providers to understand that the law is supportive and under what circumstances can someone seek an abortion. We also, even if the law says that it's allowed, that doesn't mean the government is putting resources towards training providers or equipping facilities to be able to provide the care. So that's often some of the health system strengthening work that we do as well. And, depending on the ecosystem around in a particular setting, the stigma may be strong. Providers may not understand the law, and they may feel that they will be harassed or threatened for providing abortion care. So really sensitizing providers and community members. In India, it's a more progressive environment. So it is more about just kind of figuring out what are the ways to turn on the access. So provider trainings, abortion self-use has been really growing in the country. I think we've now crossed the threshold of served with abortion
Yeah.
Maybe we can go to the next question.
There's a question there.
Yeah, forgive me if this is outside of your area of expertise, but my question is, a lot of anti-choice people push for adoption as an alternative to abortion. I was wondering if in the wake of the abortion bans, have you seen any progress in terms of demonetizing adoption or otherwise making the system stronger and more ethical?
There's definitely been more discussion about adoption laws in North Carolina. I think there probably will be some legislation around that. I think if you look at the turnaway study, though, people who are forced to continue a pregnancy who are turned away don't decide on adoption. I think people who want to choose adoption, and those who are continuing a pregnancy will continue to parent after continuing that pregnancy. So I think it's, we probably have other thoughts.
I mean, you're right. It is I think that I don't know a ton about it, but the adoption system is really complicated. And we do talk with our patients partly out of wanting to comprehensively, counsel them, but then additionally, because it is required under state law about the option of adoption. But I think as Bev was sort of getting at, it's not just, the decision to continue the pregnancy can have some real personal costs, right? I mean, both on your physiology as a person and then emotionally. And so I think while it's important to, strengthen our adoption systems regardless, I'm not sure that answers that can fully answer ever the question of what to do if you don't have access to abortion.
Yeah, I guess I was just trying to say that, like, for people who are against abortions, you think that they would be putting work into alternatives. And I was just wondering if that's been accomplished. Like, is there, for people who are advocating against abortions, are they making progress in like helping women who are no longer able to get abortions? Other options.
I think there are some legislators who have moral opposition to abortion, but also are really trying to strengthen maternal health care and other measures. But sometimes those issues don't necessarily align. And so I think, a lot of people are talking about this 13-week ban is like, well, in Europe, a lot of countries have a 12 and 13-week ban. And we like to point out, well, we're not in Europe. This is North Carolina. The realities are very different for what people face kind of in preconception time up to that 12 or 13th week. There are huge differences in access to care, access to abortion, access to comprehensive sex education, contraception, all these other things that need to happen. And so to make the ban before you do all that other stuff, not really helpful.
Can I take the last question as the moderator to all three of you? Because Gina gave these nice examples as good news that in countries all over the world, they are reversing bans or they're enshrining the right to abortion in their constitution. And we see that in the face of what seems to me, I'm not a policy person, like a global movement towards the right. We're not seeing this abortion restriction go hand in hand with more right-wing governments in other countries. And what Jonas had said about the people at the table are the ideologues and then the scientists. And it seems like we have a public opinion that would support more access to abortion. So what makes the abortion opposition in the US or the movement unique? And then how does that sort of structure the response to the movement?
I'll let Gina go first.
Should I start? Okay, sorry about earlier. It's a great question. I think that when you're talking about the people at the table, the counter movements that we're seeing are about the people who are in the streets. And I think in the US, we did see a lot of movement in the streets in response. But I think from my perspective, something that is happening now, but needed to happen earlier was a real strong connection with reproductive justice movements who were taking a more rights-based intersectional approach, who understood that Roe wasn't actually doing much for certain groups and populations, because it's in that kind of intersectional movement building where we see power. And in order to face the people at the table who have a lot of power, whether it's money or politics, you really need a strong social justice movement. It can't just be an abortion rights movement. It has to be more broad-based and diverse. And I think that that's starting to swell here. And I think we can learn a lot from the Green Wave movement and movements in other parts of the world where there's been success. Despite, I mean, Latin America has had some of the most restrictive abortion bans in the world. And that's where we're seeing a swell of movements that are changing that. So there's hope.
Yeah, I mean, I think to sort of end on a note, more hopeful note, a lot of this information has been a little bit depressing, and sometimes we're a little bit depressed. But at the same time, you know, if you think about like movements in our country that in the past, historically, that have been led by students, that have been led by the energy of like a more progressive generation, like it can happen. And so, you know, my husband, who's a geographer, likes to remind me that this generation of students is more progressive than the past, and that we may go through a period of time where things are more restrictive and laws are more restrictive in our state. And, you know, I'm hopeful that the trajectory overall will lead towards better healthcare access for our patients, and that includes abortion access.
And then just finally and quickly, so there's not great state level stats on support on like this issue. However, someone shared with me recently a relatively robust study that was an ABC News poll that 57% of North Carolinians believe in essentially access to abortion, like no legal limits on access to abortion care. And our lawmakers are about to do something that is not consistent with that. And I think that even though the majority it appears to be on one side of this issue, I think that it's not necessarily an issue that is salient for all people at all times, or when they go to the ballot box, or that they think about it at all times. And I think it probably lack of access, unfortunately, does galvanize that support. And so I agree with that. I think it is a bad period coming, but I think that the arc is positive.
Thank you.